Senator Ruane, you have 6 minutes, please, altogether.
Thank you, Professor, for your presentation. I think it's a very important topic that we don't talk much about, and it was a comment that you said around the women who are left behind that's kind of got me really thinking over the last few minutes about, the women that can't travel or can't access abortion, that may be in the mental health system. For whatever varying reason that may be in terms of how severe or whatever that their mental health issue is, and without identifying women. In my career in addiction, I've watched women with dual diagnosis, and I remember one woman wanting to access abortion very early on and not being able to, and not falling into that, not falling into the pregnancy of life, because they seen her as presenting with addiction and not actually with the diagnosis of dual diagnosis. And I remember her just kind of giving up on that. But then I watched her fight for a long time when she did continue with the pregnancy that she didn't want to, then have to fight through the courts to try and hold on to that child. So she was re-traumatised over and over again for her mental illness. So she couldn't win in any way, and I think some people have this impression that that pregnancies that continue, that somehow they're glad that they did and they go off and they have normal, happy lives and everything's okay. And I'm wondering, can you comment to some of those women that, because how we have treated people with mental health in this country, I mean, if you have got a physical illness like cancer or something, nobody accuses you of not being able to look after your children. But if you have a mental illness, people will try and assume and try to say that you are not capable of caring for your children. So, what kind of support is there for women in this situation? And, can you just, obviously without identifying stories, but maybe just to speak to some of those women that have found themselves in that situation. My other question is, when we looked at the risk to health, physical health, we looked at, the witnesses that came in were very clear that there's no one moment in time where you can identify or regulate or create legislation of that time when you all of a sudden become serious risk. So I'm wondering, because we're looking at, making no distinction between mental and physical illness, does that same principle underpin mental health in relation to there is no moment in time that you can go that this person has now transferred from a minor risk or to a serious risk? And maybe if you can comment a little bit on that. Thank you.
Senator, Professor.
Thanks. You've brought up a lot of points there. I think, the point about the woman with the dual diagnosis, that shouldn't arise. If somebody is suicidal, they're suicidal. And if they're suicidal because they're pregnant, well, the analysis doesn't have to go below that unless there's a treatable mental disorder there which is making them suicidal and isn't related to the pregnancy, if you see what I mean. So, I have to say that if that happened, I mean, situations are very complicated. So I guess third-hand information is very difficult to comment on. But so I'll talk about perhaps my own experience instead of addressing that directly. I think, yes, some people have very complicated lives. They've complicated lives because they were born into situations of deprivation that are unimaginable to a lot of us. Children are neglected. They're left in dirty nappies. They're not spoken to. Nobody gets them up in the morning to go to bed. I've got a lot of contact with TUSLA because a lot of my patients were brought up like that. And of course they need psychiatric services in adulthood. And of course they have difficulties parenting. So, it begets a cycle. If you don't have control over your own reproductive fertility, if you don't have control over whether or not you have children, if we can't practice responsible parenthood, well, this situation of deprivation is going to continue. So I think it is a very important societal point. If you have somebody with dual diagnosis, I would say that increases rather than diminishes the risk. And on the other hand, if a woman changes her mind during a pregnancy, if she initially has an unwanted pregnancy and then decides it's wanted, well, that wish should be respected. I mean, I think the same choice that pertains to choosing whether or not you want to continue with the pregnancy also pertains to whether or not you want to be a parent if you continue with the pregnancy, even if you're being forced to continue with the pregnancy. So I think choice is terribly important. And if a woman does want to continue with the pregnancy, and if she is in dire circumstances, what we need to do as a society and as a medical service is to intervene with all the supports that we can muster to help her. And that is what good practice is. We really try to break the transgenerational transmission of deprivation by really targeting young mothers who have children and who want help. And it's very satisfying work, because the children benefit from it. The mothers develop great confidence in their own lives and in their abilities to mother. So I think that interventions, when we're talking about abortion, we're talking about parental care as well. We're talking about all those other services. I think this debate, allows us to talk about those issues that we couldn't talk about previously, because now we can actually talk about very difficult parenting. We can talk about children perhaps that weren't wanted and that became wanted, or children that simply are not wanted, and the state may have to provide for those children, or they may have to have alternative parents. So it is a very complex area where we will, but my experience has demonstrated to me, just to finish on that point, that it is tremendously satisfying, and it can be done, intervening when families are young, to try and help women parent, regardless of whether those children were even considered, whether wanting them was even a consideration. So yes, we need that as much as we need abortion services. I don't know if that's the question that you were asking.
6 minutes, please.
Presentations. I have 3 questions. My first question is to Ms Blackwell and Dr Ogan. Professor O'Malley outlined a number of potential options for how verification of pregnancies arising from rape could work, such as self-declaration, formal criminal proceedings, a special form of expedited adjudication process, police reports, medical reports, or a prosecutor's certificate. As service providers, can you comment on the feasibility of these sorts of conditions in general, and how they would interact with your processes for providing care for women? My second question is to Dr Ogan. In your presentation, you outlined 3 options that you offer to women who wish to access care. Option 2 and 3 allow for women to receive care if over 18 without reporting the incident to An Garda Síochána. If we were to legislate for the involvement of the criminal justice system in assessing access to abortion on grounds of rape, do you think this could impact on your ability to dispense care without involving the guards? And my last question is to Mr O'Malley. You reference in your presentation that in later term pregnancies arising from rape, that a balancing of competing interests between the woman and the unborn child is at stake, and that some sort of legal adjudication may therefore be required to judge these competing interests. However, if the Eighth Amendment was to be repealed and an explicit right to life of the unborn removed from the Constitution, does this balance of competing interests really continue to exist in the same manner as you have articulated? Thank you.
Thank you. Ms Blackwell.
Yeah, I think, and thank you, Senator Ruane. In terms of the care for women in the context of provide, this is exactly why we raise it, is because of our concern in relation to this. Of the 12,000 odd calls we took last year, over 400 of them were silent calls. So there were people who picked up the phone and weren't able to talk to us day one. So even saying, I'm calling that number, coming in our door, is a big deal for a whole lot of people. And we are concerned that it can take time. Some people will go and report their rape immediately to the Gardaí, that's fine. Some will take a very long time to do it. And that's a concern we have. If you have to self-declare, even if it's a simple form of self-declaration, someone has to sign a certificate at the far end of it. So yet again, the woman has to put herself before someone who has a choice whether they believe her or not and signs the certificate or not. This is in the context of people who are traumatised by the rape, whose consent has been taken away from them, because that's the essence of it. That is our concern about any form of certification. If there is an adjudication process, they just won't do it. A lot of them, and they won't be able to do it within the context of a crisis pregnancy. So we are quite clear that it is not in women's interest to have to go through a reporting process in order to access abortion or any other medical service. Women should not have to do that, and that's why we raise it. I'll pass over to Dr. Ogan, I think.
Absolutely. I cannot see how it would be feasible to have an adjudication process that is based on some sort of examination that just does not exist. For the guards detect the crime using all the various pieces of evidence they have, including the physical evidence and the DNA evidence, but none of those singly on their own is conclusive. And there isn't an examination that you could subject somebody to, even if it were appropriate to subject them to an examination, but there isn't an examination you could subject somebody to that could confidently determine whether or not rape had occurred. So an examination or some sort of adjudication in that way is not appropriate. And again, a disclosure makes it difficult for all the reasons that Noeline Blackwell has mentioned. In terms of whether option 2 and 3 would be precluded from being offered if we then had some sort of mandatory reporting, it's because of Children First and the Withholding of Information Act that those options are available only to those over the age of 18 years. But I can't see a place where it would be appropriate for us to have a mandatory reporting to An Garda Síochána or some other third party before somebody could be approved for termination of pregnancy. But even if there was some bizarre scenario where that existed, I think that would be separate from us being able to still offer these options 2 and 3. We would always aim to offer care not just for those who wish to engage with the criminal justice system, but also for those who are adults and who wish not to.
Thank you.
Just very briefly, I accept that, of course, the question of the kind of testing or the verification process that might be needed or deemed necessary in the event of abortion being sought on the grounds of rape would depend very much, as I said at the very outset, on the fundamental law that was put into place in relation to the availability of abortion generally. So that if, for example, it was if abortion was freely available for a certain period of time, in all probability this issue wouldn't arise. But what I'm saying is that if you eventually decided that there was going to be some kind of a balancing test to be struck, as there is at present, maybe not the same balancing test, but some balancing test where the right to life of the unborn was still an issue, well then I think probably on constitutional and other grounds it would be necessary, or at least desirable in many cases, to have some method of, if you like, evaluating or validating a claim that rape had taken place as a basis for abortion.
Senator Ruane.
Thank you, Chair, and thank you both. I think with every word you say and every detail that you disclose here, I have to be honest, my heart is racing in my chest. So, and I haven't experienced what you have experienced, so I can only really thank you for taking what is nothing but trauma and transforming it into a fight for change, and I can't really express my gratitude enough to you both and to the people that you represent. I've one question only really, and it's because you both have mentioned around severe anomaly and the lack of discussion on it, and maybe if there was a lack of discussion there, maybe this would be the best time to discuss that at some level in terms of what you feel should have maybe been discussed, or maybe use support women that have had severe anomaly, and maybe it's not the first time, because we have spoke about multiple pregnancies resulting in the same thing, and everything that brings and and how relative and individual that a diagnosis and its impact actually has on every woman and also every family. And I mean, we look at everything that has to be taken into account with severe anomalies in relation to the finances, in relation to whether there'll be someone to care for your child if you grow elderly and you die, and what happens to that child then if it has a severe disability, and the impact and the burden on maybe its siblings, or if there was another child in the household with high needs. And maybe, I don't know whether that's the type of discussion that you were saying was lacking at the Assembly, but maybe you just want to comment on that in generally, or add anything that you feel would be appropriate. Thank you.
Thank you, Senator.
Thank you. I think parents and families who've been affected by a diagnosis of a severe anomaly have been quite underrepresented so far generally. A lot of them are quite understandably anxious about speaking out as publicly as we are. They've seen how some of us have been treated publicly, and they're naturally concerned that they're going to be vilified, spoken about, and said, you know, I'd be stoned if I said, because they feel that that's how much society and people would judge them for the decisions that they make. But I think it's really important when we look at this that we put the pregnant woman in the centre. You know, there's a real person there who was trying to have a baby and was trying to bring another member into her family, whether it's a first or a subsequent, and she got this news that you know, a lot of things need to work right for us all to be born, and sometimes nature is cruel, and things just don't work out that way. They don't develop that way. You know, the consultants have spoken about the rate, the high proportion of miscarriages that are attributable to fetal anomaly, you know, and there are other obviously contributing factors there. Sometimes we don't miscarry. Sometimes it carries on, but the baby is severely compromised. I think, speaking to women, they've spoken to me about the rest of their family. They've spoken to me about their other children. Sometimes they have other children who have severe conditions which are taking up all of their time and energy, which they're reliant on charity for, that they're carers 24/7, 365. They're trying to have a normal family existence with their other children, and they know how difficult life is for themselves, for their families, and for other children, and they find that in trying to have more children, sometimes they have to face this again. There isn't a one-size-fits-all. We all have our own family units. We all have our own challenges in life, and it's no easy task to try to cope in these circumstances. And a woman is going to make a decision based on her immediate family, based on other environmental factors. You know, has she got family support? Has she got enough money? How is she coping with her life currently at the moment? Does she have underlying physical or mental health conditions? What age is she? What's going to happen if this baby that she's expecting is going to have serious quality of life issues, but that'll not necessarily shorten their life? What happens when I can no longer care for this adult dependent child? Are my other children, is this something that I'm having to ask my other children to do? Is this something I'm going to be actually depending on the state to do? And they'll take a look around. What's not a factor in there is the Constitution. They're not saying, oh, well, the law says I have to continue with my pregnancy, therefore I must. The law as it stands just interferes with them accessing the care that they may choose to take, that's in the best interest for them, their family, and the baby. And it's their parenting decision to make. But I think if you collectively here want to create a situation in which more women will choose to continue with the pregnancies, then you need to provide a better environment for them to do that. You need to have better social supports. You need to be looking after carers better. You need to have better facilities in place for people with additional needs. And if you do that, if you have money as no object and skilled people are no object, and there's this utopia, you're still going to have people who will choose to terminate a pregnancy, and you'll still have a responsibility to support them in that decision. And we certainly shouldn't need to try to bring other families out into the open to explain their personal circumstances for you to imagine that scenario. I think anyone who's been pregnant, anyone who's contemplated having a family, we all know going through the pregnancies, anything can go wrong, anything can happen. We're all afraid of getting the bad news, and I think most of us can understand that people sometimes have to make very difficult decisions, and they need to be supported in that. But I think it's a wider societal issue. I think just saying, oh, here's the law, here's a medical service that we are or aren't prepared to benevolently provide, that's not the solution. It's not a solution for, it's not a solution against it. It's a wider issue than that.
Thank you very much.